Hi, I'm Neelum Aggarwal. I'm a cognitive neurologist at the Rush Alzheimer's Disease Center here in Chicago. And today I'm going to talk to you about mild traumatic brain injury, cognitive decline, and impairment. As we get started, we're going to talk about TBI and the overview of it, the prevalence, the impact, potential mechanisms, and also strategies and populations at risk. So moving forward, let's talk about mTBI and ACE, adverse childhood experiences, and thinking about them as a risk factor for cognitive decline and impairment. We can go over the impact, we'll talk about mechanisms, and then we'll think about prevention of ACE as a means to reduce long-term risks for strategies and the specific populations to target. mTBI is also related to violence, and we're also going to examine the mechanisms in play and strategies and populations at risk. And finally, we're going to talk about mTBI and falls, the impact of falls, the mechanisms that we feel are in play when it comes to falls, and also the strategies to prevent the falls. So let's talk about traumatic brain injury across the lifespan. Traumatic brain injury can affect 2.5 to 4 million people. This is most likely an underestimation, but what we do see is that the prevalence of TBI is bimodal. What that means is that the incidence of traumatic brain injury occurs either at the very young ages or at the older ages, with middle ages also experiencing mTBI. The other thing to note is that the number one reason for mTBI coming in through the emergency room for children is that children are either being struck by or against an object. The middle ages, it's mostly due to activities, namely athletes being struck or having an athletic injury, a motor vehicle accident, assault, or we're seeing injuries sustained by a military personnel. If you think about mTBI as a risk for cognitive decline and impairment, we also have to think about concussion. We've used that term in the past, but now we're using the term mTBI to signify concussion. And there are over 3 million concussions reported in the U.S. This is an underestimation again, and most likely these concussions are coming in through the emergency department when people are coming in with a head injury. What happens with concussion is that the temporal lobes and the frontal lobes of the brain are the lobes that are affected the most. And with that, one can start seeing changes in memory, in addition to injuries to the neck. Repeated concussions are a very big concern for us, and they're called repercussions. These are concussions that occur after the first concussion has not resolved. And we know that these concussions can lead to dementia and cognitive decline. The other thing that we're also concerned about when it comes to memory loss and dementia is that chronic concussions can lead to chronic traumatic encephalopathy, CTE. On this slide, the pictures in A and B really show you what we feel is happening as a mechanism for concussions. So the first slide is showing you a concussion that is occurring, and we're hoping that the recovery will bring us back to the pre-level concussion of memory functioning. The reality, however, is that the levels often are not reached. And you can see with the yellow line, it's showing you that it is much lower than what the pre-morbid condition was. If you look at the diagram below that, you can actually see different things are occurring. Not only is the level not the same, we feel that sometimes neurodegeneration processes may be in play here, and that is leading now to a potential case for cognitive decline and dementia. The thing about TBI to remember is that it does increase your risk for dementia, and it doesn't matter if it's mild TBI or moderate to severe TBI. The risks are over 1 up to 3 times for developing cognitive decline and dementia with mTBI. So one question we're wondering is, what are the biomarkers for mTBI? Biomarkers are very important for any kind of investigations with cognitive decline and dementia, specifically blood biomarkers. What we do know with mTBI is that there's a disruption of the blood-brain barrier, and when that happens, there's a leakiness that occurs. That means cells that are damaged are now able to move across this barrier and cause more damage. There are some proteins that we're investigating right now to really show what are involved with mTBI and how those are then leading to further damage in the brain. Another area that's very interesting is genetics. Are there genetics that could predispose you or someone having a head injury into developing a mTBI, post-cognitive decline, or possibly dementia? This area is relatively new, it's under investigation, but the ApoE genotype, which we hear about a lot for Alzheimer's disease, is investigated here also. And what we think is that if you have an ApoE allele, you may be at a higher risk of developing post-mTBI sequelae, namely cognitive decline and dementia. The other thing that we're looking at is BDNF. BDNF has been examined quite a bit when it comes into exercise, when it's coming into just general activity, physical activity in the brain. And here there are different alleles that are being looked at to see if they could somehow have an impact on mTBI and post-mTBI sequelae. We have to think about now cognitive decline strategies, and especially when it comes to falls. When it comes to children, we're seeing a lot of gains made when it comes to helmets, whether it be car seats, booster seats, and even in playgrounds, things have been modified in the environment. And because it's starting at the young age, we're now moving it through middle age and into older ages, where we're really focusing on what the environment can do and how we can modify this to prevent mTBI. So when we think about mTBI and the relationship to ACEs, I think these two charts are really helpful. The first chart is showing you when people are asked about issues related to abuse, what the population is responding that they've experienced emotional abuse, physical abuse, or sexual abuse. On the flip side, if they're asked about household challenges, environment, a fair number have mentioned intimate partner violence, substance abuse, mental illness, divorce, incarceration. So what this is really showing us is that we do have ACEs that are in our population, and that the disparities that we're seeing with ACE are really focusing a lot on our women and our racial and ethnic minority groups. This also shows you the prevalence of how many people not only have had, let's say, one ACE symptom, but more than one, 4 or more. And that is something that we're looking at. The number of these ACE experiences, again, ascertained by a survey, is that leading to a risk of cognitive decline and dementia? Okay, let's talk a little bit about mTBI and relationship to ACE, really looking at potential mechanisms. There is an intersection between ACE outcomes and TBI risk factors that we can see, and also dementia risk factors. But let's think about it with medical. We do know that there's an association with poor health behaviors and outcomes. Heart disease, cancer, and diabetes are the big three. If you take a look at the pyramid, you can see how it's a foundational pyramid where one thing layers on another, so that when you get to actually experiencing an adverse childhood event, that then starts to lead into neurodevelopmental changes, social emotional changes, adjustment changes, and really poor health risk factors start to come into play, ultimately leading to death. This kind of a continuum is what we're trying to intervene with and trying to see if we can somehow really reduce the effect of any ACE experience that a person may have had to slow down this mTBI and sequelae of mTBI. Some of the strategies, that I mentioned earlier, they're multi-pronged, as you can see here. It's not just going to be strengthening economics to support the families, but it's also going to be promoting norms and society norms. What is acceptable, what is not acceptable behavior? And the last is to intervene and really look at what we can do for treatment. So people that have experienced these issues, where can they get treatment? Whether it be substance abuse treatment, whether it be family counseling. But we feel that if we can reduce these ACE incidences with treatments, it's going to prevent further decline of the population. So moving on, as we talk about mTBI and violence, it's a very sensitive topic. Childhood abuse and neglect is the one that's most common. We do know, though, however, that abusive head trauma is the leading cause of physical child abuse deaths in the U.S. under the age of 5. What we haven't talked about a lot has been intimate partner violence, and this is now coming up more in the research, and it really came to light, unfortunately, with COVID, where the calls were coming in, these violence incidences were being reported. So violence not only causes head injury, but it also causes neck injury. In fact, in one study, 30% of domestic violence survivors reported a loss of consciousness, and 67% had residual symptoms. TBI remains undiagnosed among domestic violence survivors, and that has a lot to do with the sensitive nature of what is being asked of people to report. And then domestic violence survivors who also have TBI at times have symptoms that are mimicking perhaps a psychiatric issue, anxiety, depression, or they are not coming into the clinical care setting. They're missing appointments, or they're not following treatment plans, overall having poorer health. The continuum of how to examine this is really more of this type of socio-ecological model that you see here, starting with the individual, moving all the way out to the community and to the social aspects. If that is how we're going to understand these potential mechanisms, we have to really focus on each sphere. So there's multifactorial benefits of ACEs and early intervention, as we've talked about. Early intervention really has the opportunity to reduce the risk in an exponential manner. And if we reduce this in childhood, long term, we could reduce the incidence of cognitive decline and dementia in older adults. The last comments I'm going to make have to do with falls. Falls are very, very common, not only among young, but amongst older individuals. The rate of falls and complications are twice over their age of 75 years of age. What that means is that we are now seeing injuries due to falls. Hip fractures, arm fractures are very, very common, and what they lead to is disability. The incidence is higher in certain patient populations, namely patients who have neurological conditions such as Parkinson's disease. We also see this in post-stroke and institutional elderly. When we think about risk factors for falls and trying to mitigate those risk factors, we can think about looking at walkers, looking at safety in the environment, and trying to ensure that people undergo a risk assessment. The risk assessment that we commonly think about is called ACOVE, Assessing Care of Vulnerable Elders. And what this assessment does not only assesses risk, but also really focuses on treatment. It has been validated. We can see a reduction in falls in people who undergo treatment, and the treatment can be informed in strength training, balance training. This slide is a little bit not intuitive to many. It's showing that if you have a fear of falling, you actually have a higher incidence of falling. And that is something that we've understood through the research. And the different areas you can see on this slide are showing how is that happening, whether it be from withdrawal, whether it be from lack of use and strength. So some of the things that I mentioned earlier, whether it be gait training, whether it be strength training, whether it be Tai Chi, all of these activities have shown to increase stability and therefore are effective mechanisms or interventions to reduce falls and prevent, again, cognitive decline. We also know that aerobic conditioning is important, so walking remains as the number one exercise that we advocate for to encourage everyone to keep walking, and that can reduce the risk of falling. In summary, prevention of mTBI and its sequelae can be achieved by reducing the circumstances that could lead up to an mTBI event. In addition, targets must include the children, middle-aged, and elderly, to form a continuum of how we address not the immediate issues, but also preventing long-term consequences of mTBI. There are multiple social models that we have to use. They have to focus on community engagement, and the treatment for risk factors associated with mTBI will have a large and compounding impact to prevent cognitive decline and impairment. I hope that you've learned a little bit more about mTBI and how it intersects with cognitive functioning and decline. Thank you.